Ready? Okay. Hi, everybody. I'm Carrie from the coronary ICU, the clinician. I brought Sarah Decker here with me, the clinical coordinator from CICU. We are just going to talk about a TAVR. It's a procedure that it's a transcatheter aortic valve replacement. It's done through the femorals usually. Last week we had someone come up with subclavian access, but normally it's through the femoral artery. It's a minimally invasive procedure. It's 2 sheaths, one in each bilateral groin, and they insert a wire, then they insert a catheter up, they inflate a balloon, and then they inflate and then they deploy a valve. There's a video. This video is really good, kind of gives an overview.
And the music's super snazzy.
Yeah.
That's the valve deployed at the end of the procedure. That's your calcified aortic valve. You notice the heart is fibrillating. They'll have a pacemaker wire in there that stops the heart so they can deploy the valve.
They'll have, transvenous from the RV. There's the balloon already there, and then here comes the valve. That's just kind of an overview of the procedure. It's minimally invasive, like we said. It's usually the transfemoral approach, and they do some apical, but they would go to cardiac surgery usually post-op from that. Why would we do this versus a AVR? It's usually done in patients in the elderly population. The surgeon usually identifies patients who are at high risk to undergo that big surgery, so they do it. TAVR is usually, I don't know, they're pretty, I would say above 70, around 80 years old.
I think typically like 80s, even 90s. I think the oldest one I've taken care of is like 90, 92.
92,
so.
yeah. Severe COPD, severely calcified valve, they'll do it. Usually the surgeon, though, pre-op and when they're doing all the planning, decides. Complications, when the biggest complication is a stroke, and that's because when you open that valve, you can flush emboli. So we do frequent neuro checks. AVIs, we do neurovascular checks because you have bilateral groins, you have sheaths in your artery, one of your veins, so you have to do neuro checks. They do an AVI pre-op in Gateway or wherever they meet pre-op these days. And then that'll be charted, that'll be in IVU. When they come up to CICU, we don't do AVIs unless there's a pulse change. Delirium, you're dealing with an elderly person, so sometimes they're a little delirious. Pain, bleeding. Most patients when they come out of the OR are a little hypertensive. So, and they have an A line, so we just kind of watch things for a little bit. And immediate post-op. We do site checks, we do vital signs, pretty much.
And the key point is you want their MAP below 90, and this will help prevent the wing bleeding. So MAP goal less than 90. Sometimes we start them on a claviculae strip to keep their blood pressure controlled. And then another on that previous slide too is the cardiac dysrhythmias. A lot of times we see patients go into complete heart block right after.
Yeah.
I would say that's really common. So some of those patients require transvenous pacers to be placed back in.
Or they'll come out with one.
Yes, or they'll come out with
Yeah.
one. So kind of just keeping an eye on the blood pressure and the heart rate specifically.
Yep. Yep. So the greatest risk is stroke in the first 24 hours, and that's just like we said, that you could shower emboli. So I have a slide. Linda, would you mind going? It kind of gives you. Keep going. Limb ischemia pulse rates. Okay, oh, that's how to do ABIs. Is everybody familiar with doing ABIs? If not, there's a good video to watch. But keep going. Delirium. And at the sites, also a pseudoaneurysm, just because you have bilateral sites and you might have a bruit or a hematoma there. So we keep them on bed rest for 6 hours post-op. Okay, sorry. The way we do vital signs, it's a little different. So there's a chart that we'll get to it eventually. Here it is. So, and I'll give you a copy or whatever. It's going to be on this as well. But neuro checks, limb checks, and vital signs, and it's just a different sequence of how to check them and do them. I mean, not do them, but just keep yourself organized, because you do the vital signs longer than you do the limb checks and things like that.
Yeah, unfortunately they don't line all the way up, but you can see the pink boxes are all the Q15 minute checks. And so you have your neuro assessments, Q15 for the first hour, then it goes to Q30 for 1 hour, and then Q2 hours for 24 hours, or sorry, 22 hours to a total of 24 hours is how long we're watching these patients. And then get down to the limb is in the middle box, and so that's Q15 times 4, Q30 times 2, and then Q1 hour. That's just checking your pulses in both legs. Vital signs are Q15 for 2 hours, so that is a little bit longer just because, like we talked about, the risk of the high blood pressure and the low heart rate or heart block. So.
Okay, you can keep going.
And we actually keep that chart at the, as soon as we have our patients come up, we grab that guide and kind of just check it off to keep us in sync, because if you get tied up and you have a buddy watching your patient or whatever, they can help you out and know right where you are, so.
And then with every patient, we keep this at the bedside in the CICU, and it's just kind of like a tip sheet, so you can, like what to look for if you get behind, or that's also with the documentation form. But I have this tip sheet that I could also share with your staff. Just kind of an overview of what the procedure is and things like that. But at immediate post-op, you're checking vitals, you're checking the groin, you're checking pulses. Patients do have some pain, so whatever method works for pain control. Blood sugars, we keep them below 200.
Are you guys still using the TAVR subphase, or are there any specific
Like
orders
the
that?
power plan?
Yeah.
There is a power plan, transcatheter replacement. The doctors will order that, and they just pick what we need to do.
I guess going back to pain, if there's a key point is if any back pain, you'd be concerned for a retroperitoneal bleed. So if they start to say, it's tender down here, and when you're placing your fingers there to see if the groin is soft, obviously that can be very tender. But if they're complaining of any pain down here, up here on the back, that'd be concerning. So.
And we have called quite a few stroke alerts post-op right away. And what we've learned is sometimes these patients are at their baseline, but we just don't know that. So I think that, the attending comes to the bedside and he's like, oh, no, or she's like, no, they had that droop pre-op. So we have communicated a little better and documented a little better with our teams, just to say, hey, he does have slurred speech. So post-op, this isn't going to be something different. But I think that helped us, because I felt like we were calling a lot of stroke alerts for a while.
Which is the right thing to do, you know,
Yeah,
if you really
absolutely.
feel, if you don't know the patient's history, you don't have a good history on their neuro assessment, sometimes we recruit the attending or family, or, you know, just a quick assessment from the patient saying, you know, is this people usually abnormal and that sort of thing, but.
Yes, and we changed just recently, the docs, at first they said patients need anticoagulation post-op day, post-op day 0. They need an antiplatelet, and anticoagulation. So we were given like Plavix, aspirin, or ticagrelor. That's kind of stopped now, so it's really dependent on what the physician wants. They will take it before they come in the morning, but post-op, they'll, it's kind of driven now about what the doctor wants. We've had some bleeding, and so now it's based on the doctor's orders. So I put that right here, just kind of, everything basically says consult the physician or the attending. There's a nurse practitioner that works with the TAVR patients, and her pager's on here as well. She's very helpful too.
All these resources are on the QQ and cardiac
Yep.
surgery internet homepages for you to pull up. And on the extreme end of the stroke thing, when we had them on our side of the hall, we had several have to go for immediate thrombectomies. Before we even locked the wheels, when the patient rolled out of the OR, they were already in the process of having a stroke, and the nurse was able to tell. So you have to be assessing that from the second you lay your eyes on them.
Yeah.
Yeah, we usually have a team that comes in, and you've got a couple nurses there. Somebody check the grid sites and the pulses right away as handoff is happening, as well as doing a quick neuro assessment. That way to kind of squash that. Is this new or is this normal? So, and a lot of times what we'll do is grab a Sharpie and kind of mark where your pulses are. Just in that moment, you know, when you're trying to find it, sometimes it can be hard to find. So, kind of.
Questions?
Do y'all have any questions about TAVRs? Thank
I will,
you.
Go ahead and move on to TEVARs real quick then. And again, all these are on the intranet homepage. Pretty easy space to find, just so you see where you went. Cardiac surgery ICU page is on the SharePoint right here, and coronaries is, are you guys under coronary ICU or
Yeah.
PACU?
See ya, coronary.
Okay. And then if you hover over libraries, you'll find, that's where you find all the folders, and I'm on the cardiac surgery page now. This is TEVAR, TAVR. Oh, no. All right, pick your name, Nicole. Why is it doing this? All right, here we go. All right, we're gonna talk about TEVARs now. So TEVAR is a thoracic endovascular repair, and it is aortic repair. And basically in this situation, your thoracic aorta is the problem. And many of you guys are already taking care of EVARs up here immediately post-op before they get sent down to us with the vascular team. The difference is where the aneurysm is on the aorta. So, just to review real quick, aneurysms are a bulging of the aorta where the wall has thinned out for a number of reasons. It can be related to hypertension. It can be a genetic thing. We see a lot of this run in families. Often, though, it's related to uncontrolled hypertension over time. Or sometimes there can be some trauma that might induce a problem that escalates over time. And you can see that the aneurysm can occur in many places. On this particular slide, for whatever reason, they don't show any ascending aneurysms. But any kind of ascending aneurysm is considered a medical emergency, and they're automatically going for a surgery. Whereas some of these can be medically managed, and I'll discuss that in a minute. But this part would be considered just thoracic. Once you cross over the diaphragm, that's where it really starts to differentiate between thoracic and abdominal. If you have it on both sides, it's thoracoabdominal. If it's just below the diaphragm, it's abdominal. And then if you keep moving down, it can get close to the bifurcation of the vessels. Whereas dissections is where you've developed a false lumen, and now there are two pathways for, whoops, look at that as a touchscreen. There are two pathways of blood. And the problem with, as we know with dissections, is that the body and the brain really only recognize the blood that's in the main lumen. So if you have a certain portion of your volume in a false lumen, the compensatory mechanisms kick in, where then the patient becomes very tachycardic, the blood pressure becomes very high, because the goal is the heart's trying to say, I've got to hold on to all this volume that's missing, not realizing that the volume is actually still there and it's not getting to where it needs to go. There are different classification systems, and for dissections we typically talk in type A and type B, which is the Stanford classification. Type A is any part of the ascending aorta, and type B is always descending. And occasionally we have patients where it covers the whole shebang, and this will be multiple surgeries in several steps. All right, so if we look at what our options are, we can medically manage them, and that includes things like blood pressure management, pain management, and frequent imaging, where they'll be brought back every 6 months or so to see if it's getting any bigger, or if they're starting to hurt more, pain's increasing, they need to take a look then. They will choose intervention if the aneurysm is greater than 5 centimeters or 2 inches in diameter, is increasing in size from image to image over time, or there's continued or new symptomology. And our 2 choices for intervention are open surgery or closed. So open would be putting the patient in circulatory rest, opening their chest depending, or thoracic incision depending on which part of the aorta you're working on. If it's descending, they're going to go through the side. If it's ascending, they're going to go through the mid-sternum. They'll go on cardiopulmonary bypass, they'll be put on circle rest, they'll get cross-clamped. In this picture here, it's hard to tell from this direction, but if you were up closer, you would see that there are 2 clamps that are clamped above the injury and then below the aneurysm injury. And what they do is they stop blood flow to that area. They cool the patient down to a very cold temperature, and they essentially temporarily stop that flow. So we know that there can be consequences in that over time. Their goal is to get that cross clamp off as soon as they possibly can. Our choice for closed is the TEVAR, and I'm going to show you a quick video. I just got to drag it forward to where we want to see really quick. This guy's I think he's from Stanford, and he's
Fenestrated brain stent grafts is planned using a computed tomography angiography or CT scan. This test allows us to make precise measurements of the aorta. Based on these measurements, we can select the ideal fenestrated brain stent configuration for each specific patient. In this example, a stent was planned with 2 small cups and 2 fenestrations for the arteries of liver, intestine, and both kidneys. The operation is done with small incisions in both groins. Working inside the arteries, we can obtain access to these vessels. In this segment of the video, a dye is injected into the right kidney artery to locate the vessel. Following location of the vessel, the aortic stent is introduced inside the artery with a delivery cannula and is released in the aorta. Working from the arm with catheters, we can access the small cups into the arteries of the liver and intestine, while the arteries to the kidneys are accessed from below. Once all vessels are safely secured, separate side stents are placed into these arteries, followed by an additional stent to connect the repair to the arteries that go to the leg. What are the expected results? The benefit of a fenestrated and brain stent graft builds upon the success we have had over the last.
I want you guys to get a good view of what that looks like, because if you think of all the major vessels that branch off of the descending aorta to the kidneys, to the mesenterics, to all those organs, they have to often, in certain process, they might have to ligate off those vessels, put in the stent graft and reattach, or as you can see, they can potentially do a fenestrated process where they can just drop the graft down into those vessels. So post-operatively, we're always concerned about renal failure, gut ischemia, and the like. Post-operative big complications are infection, bleeding, and then paraplegia. And where paraplegia becomes a big risk is that we have to think about the fact that the aorta sits right next to the spine, and the aorta has blood vessels that branch into the spinal column and feed blood and oxygen to those spinal nerves. If blood and oxygen cannot get into the spinal column, to those spinal nerves, those spinal nerves would die. And the areas that those spinal nerves innervate are the lower extremities, and that's where the patient can develop paraplegia.
David Stapleton, please caller, come to main control. David Stapleton, main control.
What we have to think about is watching for signs of paraplegia. When a patient first arrives out of the OR, we do an immediate, we wake them up. You have to wake them up, and you have to check their neurological assessment, unless there's some other extenuating circumstance that keeps you from waking them up. Your baseline assessment is at that moment where you're waiting to see what their movement, and you're not just having them do this, they need to see if they can do this off the bed, and you gotta see how strong they are on both sides. You also wanna assess their upper extremity strength as well. Everybody's usually there, you're doing it with the surgeon present, we get that baseline assessment. If when you get that baseline assessment, that first assessment, the patient is really weak or can't move, then we're concerned that there was an ischemic event in the OR and that there's been some problem with blood getting to the spinal nerves, and at that moment the surgeon will be like, okay, there may or may not be something they can actually do, we just may need to watch, and we'll be doing frequent vital signs. But if your first assessment's normal, you have to remember that these neurological deficits can come in anytime over the next 21 days, usually within the next 24 to 48 hours of your high risk time. So every hour we are doing assessments where we're asking them to lift their legs, pull up. Can you feel? Is there any sensation change? Are we tingling? Are we numb? Is there anything weird going on? And if they start to have a change, that's considered a DND, a delayed neurological
please caller
deficit.
come to main control. Melissa Lagourmet.
And those are often related to our post-operative management. If we do not keep their blood pressure high enough, then the swelling that has occurred in that area will impede that blood from getting in. So you need the blood pressure higher to get that blood from the aorta into the spinal column. So our goal, mean arterial pressure after surgery, is a map of 90 to 100. And that's assuming that they're moving just fine and not having any neurological deficits. We can do that, and if you need to use some Levofed or something to keep the pressure up to that point, then that's what you have to do. If they start developing a delayed neurological deficit or they have one present on your baseline assessment, then our MAP goal will go up to 110. We will also then increase their hemoglobin goal up to greater than 10. And we may also look at whether or not we need to, hopefully the patient, if they were high risk, has already had a lumbar drain placed prior to coming down from the OR. Because the way the lumbar drain helps is if you drain off that CSF, you decrease pressure in that area where you're trying to get blood into the spinal column. And most of the high risk patients and ones they anticipate they're gonna have to do a lot of work around the vessels, they'll place a pre-op lumbar drain prior to going to the OR. They will drain during the OR, and then they'll come down to us. We then put them on our automated lumbar drain in the liquid guard, and I'll show you a picture of that in a second. Our goal then is to maintain an ICP of 10 or less, which is what the average person's ICP is. And we have an algorithm we follow for how much to drain each hour. For the neurovascular assessments, again, we're gonna assess every hour for 12 hours, then every 4 hours per unit routine. If the patient is already having neurological deficits, you're gonna do that hourly for longer. And really, when you talk about, assessing the patients, you also want to be watching for stroke, because sometimes all those things can end up going together. So keep an eye on those changes. The lumbar drain, again, it gets inserted and it sits in the spinal column. Again, placed preoperatively. Our organization has a tendency to place them pre-op. I've only had one patient have it placed post-op. Some organizations just wait because we know that lumbar drains do pose a risk for infection. They're not benign. And there's a lot of literature out there to support their use, but we have to be careful when we do use them, so not every patient gets them. All right. And when they come down, this is kind of our setup. They'll have the lumbar drain coming out of the back. This is our sim man. He's laying on his side, so you're looking at him. Ooh, I did it again. This is his behind right there. That's his back, and this is his arm, and that's his leg. And here's the drain coming out of his back. We have this little blue apparatus we set the transducer in, which is the transducer is leveled with insertion site. And this is the liquid guard, and it's a really cool device. We have the setup in, and we program it for the ICP goal we want, how much we want to drain off, and it trends the patient's ICP. And if the ICP goes above what we want it at, it starts to drain at 10, however many, like 10 cc's an hour, if that's what we've set. And if it drops below, then it stops draining. So it's not nursing turning stopcocks, accidentally walking away from a lumbar drain. If you have ever done that before and you came back and you're like, oh my God, I just drained off 30. Are they gonna herniate? That's like the worst feeling in the world, and it's so easy to get distracted during CSF drainage. So this machine's been a real godsend for our unit because it's a low volume, high risk thing, right? These are the two algorithms we have. We do have one for the Codman lumbar drain because that is what we've always had. Should we have more than one of these on the unit at the same time, we do have a liquid guard that we could borrow from the peds area. But we have a lumbar drain algorithm for Codman and one for the liquid guard. And it talks about where to set things out, what your goals are, and what to do if the patient starts to have a neurological deficit occur, and who to escalate to, and how to change the fluid drainage. So that's essentially what we do with TAVRs. Do you guys have any questions on that?
Are you guys seeing those at all?
I think most TEVARs are probably going towards straight to either cardiac surgery, and occasionally they'll go to CICU. Christoph, who just left, is the clinician from CICU, and he said that they have one down there now, but it was a big trauma patient, and they're on all sorts of traction, and so it's really changed how they have this guy asleep, and he's like can't move because of all the equipment attached to his leg. So their assessment ability is really limited right now as to whether he's in the process of having any kind of neurological deficit, because they can't wake him up and they can't ask him to lift his legs off the bed because of his traction and different things. So that'll be kind of a wait and see process as you go through. But your standard patient getting this procedure, you wake them up immediately, and they often come out extubated, which is really nice when they come out extubated, because then you can talk to them. But if they come out intubated, they'll still follow commands, and our goal is to keep them awake and get them extubated if we can.
What's the risk? What's the risk of ischemic event
After surgery,
Yeah.
the percentage, I
Yeah.
should know this because I just did a write-up on this. I'm so sorry, I can't pull it off the top of my head, and I don't want to tell you wrong, but it's.
Is it like less than 50% or?
Yeah, it's less
Okay.
than 50%, but it's more significant in patients that have extensive injury. There have been several patients that have already had deficits forming before they even go to the OR, like where they're waiting for surgery. Sometimes it's chronic, it's been occurring over time. By the time they see the doctor, there's already a lot of damage done. Sometimes it's been an acute event. And you know how this gets, some patients you find out they have a problem when they fall off the roof, that kind of thing, or they have a car accident. Oh, look, you've got an aneurysm that's probably been here for a while. But the patients like those, we already talked to them beforehand that you're likely going to have some level of non-movement below your waist after surgery. And there's some that are just so high risk that when they place the lumbar drain, they tell them that we're worried about this, or we're really worried you're going to have renal failure issues after surgery, because we're having to ligate off those renal vessels, put in the graft, reattach them, risks for clots at those sites, etc. So that's a good question. I'm glad you asked me that. I'm going to look that up because I do have that number written down. My brain's
That's
older I get.
hard. Numbers are hard.
Yeah. Any other questions? And if you guys ever, like if for some reason, and I know this happens to you guys a lot, there's a bed issue somewhere and all of a sudden you've got something plopped on you that you've never dealt with before, please call us, whichever unit it might be. We are here to help you. Carrie and I can always run out of whatever meeting we're in. Patient is always more important than anything else we're doing. So let us know and we'll come and get you straight with it, whatever we need to do.
And if you forget which one comes from which unit, just call either one of us.
Yeah.
It's going on, and we'll get you to the right
They're
person.
masters at the TEVAR. They get them out much faster. If they plop a TEVAR on our, a TAVR. If they
Yeah.
plop a TAVR on our side of the hallway, we hold on to them 5 days longer than we need to because we're surgery.
Right.
On their side of the hall,
Or
it's
get
like,
them out, yeah.
get them out, and then they're
Yeah.
good to go.
Yeah.
One thing we just wanted to back up, during the first 24 hours after a TAVR is an ischemic stroke. That's your biggest risk. But like when the patient goes home, because they're on all this anticoagulation, a hemorrhagic stroke, like within the first 30 days, because this is an elderly population, they, I don't know, maybe a little bit more clumsy at home, fall, so you have to watch. You may
And
get
a risk of, there's within that first 30 days is a risk of a hemorrhagic stroke too. So maybe telling their family and loved ones, going over the FACE acronym about looking for a stroke. Fast.
So minimally invasive versus invasive.
Awesome. Thank you.
You're welcome.
Thank you. And they're going to share the slides so that you can see kind of some of that stuff.
We'll
Up
make
close.
sure they're located on both of the internet homepages. I don't know if you want us to send them to you separate as well, or whether you guys prefer to just have them in a place like where we have them right now, where you can just go look. Do y'all have a preference? We're happy to send them to Natalie and Dion.
Either
I
way.
think the central location is probably good.
Yeah.
Because
There's also a learning exchange module about
Mhm.
TAVR and
Okay.
MitraClip that is very helpful as well.
Okay. Awesome. Thank you.